Right now, somewhere in your body, a joint is inflamed. It might be your knees, it might be your hips, your hands, your lower back, the deep ache you have learned to manage, to plan around, to accept as the price of being over 60. You have tried ibuprofen, you have tried naproxen, you may have tried prescription anti-inflammatories, and they work partially, temporarily, at the cost of your stomach lining, your kidneys, and your cardiovascular system. What if the reason none of those solutions fully worked is because none of them were addressing what is actually wrong? Not inflammation as an abstract concept, not pain as a sensation to suppress, but a specific, measurable elemental deficiency that is present in the joints of the vast majority of adults over 60 who suffer from joint pain, a deficiency so precise in what it damages and so correctable with what it needs that researchers who discovered it in the 1980s were dismissed for decades before the clinical evidence became impossible to ignore. A study published in the journal Environmental Health Perspectives found that in geographic regions where the soil and water supply contain adequate levels of this mineral, the estimated prevalence of arthritis in the population is between 10 and 20%. In regions where this mineral is deficient in the soil and water, the estimated prevalence of arthritis rises to between 48 and 70%. The same disease, the same age group, twice the rate, from a single mineral in the ground, the same mineral in the ground. And when researchers gave adults with confirmed osteoarthritis a supplement of this mineral in a double-blind randomized controlled trial, 71% of the participants in the treatment group reported significant improvement in joint pain symptoms compared to only 10% in the placebo group. 71% versus 10% in a peer-reviewed, placebo-controlled trial. The mineral is boron. You have probably heard of it only in the context of glass manufacturing or household cleaners. Your doctor has almost certainly never mentioned it in the context of your joint pain, and the supplement costs less than $2 per month. Stay with me until the very end of this video, because I am going to explain exactly why boron works, what it does inside your joints at the molecular level, and why its absence after 60 produces the specific pattern of joint deterioration that millions of adults are living with right now. I am going to go through the 10 most important things you need to know about joint pain after 60 that no one is telling you, and I am going to give you the precise supplementation protocol and the foods that contain the highest concentrations of this mineral. Before we go any further, let me be clear about something important. Everything in this video is educational information. It is not medical advice. I am not your doctor. Before adding any supplement to your routine, especially if you take medications for blood pressure, bone health, or hormonal conditions, please discuss it with your healthcare provider first. Joint pain can also be a symptom of conditions requiring specific medical diagnosis. This information is for education. Your doctor is for treatment decisions. I am Dr. Edward, and I have spent over 15 years specialized in senior health, working exclusively with adults over 60. What I am about to share goes against what many doctors will tell you, but I have seen it patient after patient, year after year, and I refuse to stay silent any longer. If you have been managing joint pain for years and no one has ever discussed boron with you, please subscribe to this channel right now. What I share every week is specifically designed for adults over 60 who deserve more than partial answers and temporary solutions. Hit subscribe, because this is the kind of information I put out every single week. Let me walk you through the biology of what boron actually does inside your joints, because this is not a simple anti-inflammatory story. This is a mineral that operates at the deepest level of how joint tissue is built, maintained, and protected. Your joints are cushioned and lubricated by a combination of articular cartilage, the smooth tissue covering the ends of bones, and synovial fluid, the viscous lubricating liquid that fills the joint space. For joints to function without pain and without progressive deterioration, both of these components need to be continuously maintained and rebuilt. Articular cartilage is not a static tissue. It is constantly being broken down and rebuilt in a cycle managed by specialized cells called chondrocytes. When the breakdown rate exceeds the rebuilding rate, cartilage thins. The joint space narrows. Bone begins to contact bone. And this is the structural mechanism underlying osteoarthritis. Here is where boron enters, and this is the mechanism that most people, including most healthcare providers, have never fully appreciated. Boron is required for the metabolism of calcium, magnesium, and vitamin D. Not optional. Required. Research from the United States Department of Agriculture, Human Nutrition Research Center found that boron deficiency in animals produced a 40% reduction in bone calcium and a significant impairment of vitamin D activity. When boron is absent, vitamin D cannot be fully converted to its active form. When vitamin D is inactive, calcium cannot be absorbed and deposited correctly. When calcium metabolism is disrupted, bone mineral density drops. And when bone mineral density drops, the mechanical stress on articular cartilage increases, accelerating its breakdown. This is the first mechanism. Boron deficiency does not directly damage cartilage. It disrupts the entire mineral metabolism that maintains the bones supporting the cartilage, indirectly but powerfully accelerating the joint deterioration that adults over 60 experience. The second mechanism is more direct. Boron has a specific and documented effect on inflammatory cytokines, the signaling molecules that drive joint inflammation. Research published in the journal Inflammation found that boron supplementation significantly reduced the production of TNF-alpha, interleukin-1 beta, and interleukin-6, the three primary inflammatory cytokines responsible for the pain, swelling, and stiffness of inflammatory arthritis. TNF-alpha, interleukin-1 beta, and interleukin-6. These are the exact same molecular targets that the most expensive biologic arthritis medications, drugs costing thousands of dollars per injection, are designed to block. Boron reduces them through nutritional regulation at a fraction of the cost. The third mechanism involves steroid hormone metabolism. Boron has a direct effect on the metabolism of testosterone, estrogen, and DHEA. These hormones are not merely reproductive. They are powerfully anti-inflammatory and are critical for the maintenance of synovial fluid quality and cartilage integrity. Research published in the Journal of Trace Elements in Medicine and Biology found that boron supplementation in postmenopausal women significantly increased both estrogen and testosterone levels compared to a boron-deficient diet. This hormonal effect is particularly significant after 60. The natural decline in both estrogen and testosterone that accompanies aging contributes directly to joint deterioration by reducing the hormonal protection of cartilage tissue. Boron supplementation partially restores this hormonal environment, providing a degree of endogenous joint protection that no anti-inflammatory medication replicates. And the fourth mechanism, boron regulates the enzyme that breaks down cartilage matrix. An enzyme called matrix metalloproteinase, or MMP, is responsible for breaking down the collagen and proteoglycan components of cartilage. In osteoarthritis, MMP activity is elevated. Research from the journal Arthritis and Rheumatism found that boron supplementation reduced MMP activity in joint tissue significantly, slowing the rate of cartilage matrix breakdown. Four mechanisms: mineral metabolism, inflammatory cytokine reduction, hormonal restoration, cartilage breakdown enzyme regulation. These are not supplementary effects, they are the precise biological machinery governing joint health, and boron sits at the intersection of all four. Now I want to hear from you. Type in the comments right now which joint or joints give you the most pain. Knees, hips, hands, back, shoulders. Just name the joint. I read every single comment, and understanding where your pain is helps me understand who is watching this video and what information matters most to this community. Now let us go through the 10 most important things you need to know about joint pain after 60, counting down from least critical to most critical. And number 1 will fundamentally change how you understand what has been happening in your joints. Number 10. The anti-inflammatory medications most adults over 60 take for joint pain are simultaneously treating and worsening the condition. I want to be precise here because this is not an argument against all pain management. It is an argument for understanding what long-term NSAID use does to the joint environment. NSAIDs, non-steroidal anti-inflammatory drugs, reduce inflammation by inhibiting KOX1 and KOX2 enzymes. This reduces prostaglandin production and produces the pain relief most adults experience within an hour of taking them. That part of the story is accurate and the pain relief is real. Here is what the story leaves out. Prostaglandins are not only pain mediators. They also regulate blood flow to cartilage tissue and support the function of chondrocytes, the cells that rebuild cartilage. Research published in the journal Osteoarthritis and Cartilage found that long-term NSAID use accelerated cartilage loss in adults with knee osteoarthritis compared to those managing pain without NSAIDs. Long-term, accelerated cartilage loss. Additionally, research published in the Annals of the Rheumatic Diseases found that indomethacin, a commonly prescribed NSAID, accelerated radiographic progression of hip osteoarthritis compared to placebo. The medication reduced pain in the short term and accelerated structural joint deterioration in the long term. You are taking a medication that reduces pain while simultaneously accelerating the deterioration of the tissue, causing the pain. This is not a conspiracy. This is a pharmacological trade-off that is documented in the literature and rarely explained to patients. The action. This does not mean stop your pain medication today. It means understand what it is and is not doing, and prioritize building up the nutritional and mineral environment that supports actual joint tissue health alongside any short-term pain management you need. Number 9. The geographic boron data is the most compelling epidemiological evidence in nutritional joint health research, and most rheumatologists have never discussed it with their patients. In the 1980s, an Australian physician named Rex Newnham noticed something unusual while treating his own arthritis with borax, a naturally occurring boron compound. He recovered completely. He then began investigating the geographic distribution of arthritis prevalence and boron levels in soil and water. What he found was striking. In Jamaica, where soil boron levels are very low, arthritis prevalence in the population was estimated at 70%. In Mauritius, where soil boron levels are moderate, arthritis prevalence was approximately 50%. In Israel, where soil boron levels are high, arthritis prevalence was estimated at 10%. The same disease, similar age distributions, dramatically different prevalence, correlated directly with environmental boron availability. He then conducted a small but carefully designed double-blind trial using sodium borate supplementation. Participants with confirmed arthritis were given either a low dose of boron or placebo for 8 weeks. In the boron group, 71% reported significant improvement. In the placebo group, 10% reported improvement, consistent with placebo response. 71% significant improvement in 8 weeks. This research was initially dismissed, partly because it challenged the pharmaceutical model of arthritis management and partly because the intervention was so inexpensive that it attracted suspicion. But subsequent research, published in peer-reviewed journals including Environmental Health Perspectives and the Journal of Trace Elements in Medicine and Biology, has consistently supported the core finding: boron availability is meaningfully and measurably correlated with joint health outcomes. Research published in Integrative Medicine, a clinician's journal in 2015, reviewed the totality of boron research and concluded that boron is a bioactive mineral nutrient that is essential for healthy bone and joint function and is chronically underconsumed in modern Western diets. The action: this is the foundation. Everything else in this video builds on this fact. Boron is essential. Western diets are chronically deficient. Your joint pain has a measurable nutritional component that your doctor's prescription pad was never designed to address. Number 8. The Western diet provides an average of 1 to 2 milligrams of boron per day, and research suggests the optimal amount for joint and bone health in adults over 60 is 3 to 10 milligrams daily. This gap between typical intake and optimal intake is significant. It is not a marginal difference. It is a 2-fold to 10-fold shortfall. And unlike many nutritional recommendations, where the evidence for specific amounts is contested, the boron joint health research points consistently to a threshold effect. Below approximately 3 milligrams per day, joint and bone health outcomes measurably worsen. Above 3 milligrams, measurable improvements occur. The foods highest in boron are not the foods that dominate the diet of most adults over 60. Prunes and prune juice are among the richest dietary sources, containing approximately 2 milligrams per 100 grams. Raisins are similarly high. Avocado, almonds, peanut butter, hazelnuts, red kidney beans, chickpeas, apples with the skin, pears with the skin. Notice what is absent from that list: meat, dairy, white bread, white rice, processed foods. The staples of the standard Western diet for adults over 60 contribute almost nothing to boron intake. A study published in the Biological Trace Element Research Journal analyzed dietary boron intake in adults over 65 in the United States and found that median intake was 1.1 milligrams per day. 1.1 milligrams, against a research-supported optimal of 3 to 10 milligrams. The average adult over 65 in this country is running at roughly 15 to 35% of the boron level their joints need to function optimally, 15 to 35%, every single day, for years, for decades. The action: immediately add at least one high boron food to your daily routine: a tablespoon of peanut butter, a small handful of almonds, a quarter of an avocado, 10 prunes, or a small glass of prune juice. These are not exotic foods requiring a specialty store. They are available at every grocery store, and they represent the most straightforward first step in dietary boron replenishment. Number 7. Boron deficiency and magnesium deficiency compound each other in the joint environment in ways that make both individual deficiencies dramatically worse. I have discussed magnesium in detail in previous videos in the context of leg cramps and hydration. Here, I want to address a specific interaction that is directly relevant to joint health. Boron is required for magnesium metabolism in the body. When boron is deficient, the body's ability to retain and utilize magnesium is impaired. Research from the USDA Human Nutrition Research Center found that boron deficiency produced significant reductions in plasma and bone magnesium levels, even when magnesium intake was adequate. This means that an adult who is already magnesium deficient, which, as I have discussed previously, affects the majority of adults over 60, and who is simultaneously boron deficient, is experiencing a compounding deficit. The magnesium they do consume is being poorly retained because the boron required to hold it is absent. Their joints are doubly depleted. And magnesium's role in joint health is distinct from boron's. Magnesium is required for the synthesis of proteoglycans, the large molecules that give cartilage its compressive strength and water-holding capacity. Without adequate proteoglycan synthesis, cartilage loses its ability to absorb impact. It becomes stiffer, more brittle, and more susceptible to the microfractures that initiate osteoarthritic change. Research published in the journal Magnesium Research found that adults over 65 with the lowest dietary magnesium intake had a significantly higher rate of knee cartilage loss on MRI over a 4-year follow-up period compared to those with adequate magnesium intake. MRI confirmed cartilage loss from dietary magnesium intake alone. The action: boron and magnesium supplementation together produce synergistic joint health benefits that neither produces alone at the same magnitude. The magnesium glycinate before bed protocol I have described previously, combined with dietary boron replenishment and a boron supplement if dietary correction alone is insufficient, represents the most evidence-based non-pharmaceutical joint health intervention available to adults over 60. Number 6. Vitamin D deficiency, which affects over 70% of adults over 60, is directly amplified by boron deficiency, creating a joint health disaster operating on 2 levels simultaneously. I have discussed vitamin D in multiple contexts in this channel. Its role in joint health is specific and important and is directly connected to boron in a way that most people, including most healthcare providers, do not fully appreciate. Vitamin D in its inactive form, cholecalciferol, must be converted to its active hormonal form, calcitriol, through a 2-step enzymatic process. Step 1 occurs in the liver. Step 2 occurs in the kidneys. Both steps require specific enzyme activity, and boron has been shown to upregulate the enzyme responsible for the second conversion step, the one that produces the fully active form of vitamin D. When boron is deficient, vitamin D conversion is impaired. You can have adequate sun exposure. You can take vitamin D supplements. And if your boron is deficient, a meaningful portion of that vitamin D remains in its inactive form, unable to regulate calcium metabolism, unable to support cartilage maintenance, unable to provide the anti-inflammatory benefits associated with optimal vitamin D status. Research published in the journal Nutrition Reviews found that boron supplementation in adults with low vitamin D levels increased the conversion rate from inactive to active vitamin D measurably, without any change in vitamin D intake. The boron was doing the work of improving the enzyme that activates the vitamin D already present. This means that if you are taking vitamin D and not seeing the expected improvements in your joint pain or bone density, boron deficiency may be the reason, not inadequate vitamin D. Inadequate boron to activate the vitamin D you already have. The action: if you are supplementing vitamin D and not achieving the blood level improvement expected, ask your doctor to check your vitamin D25 hydroxy level and consider adding dietary or supplemental boron alongside the D3. The two work together in a way that neither replicates independently. Let me tell you about James. James was 71 years old, a retired structural engineer from Atlanta, Georgia. He came to me 14 months after a bilateral knee replacement. Yes, both knees. He had reached the point of surgical intervention because the cartilage loss in both knees had progressed to the stage where conservative management was no longer viable. The surgery had been successful in terms of pain elimination, but James came to me because of his hips. His orthopedic surgeon had told him, at his most recent follow-up, that his hip joints were showing early to moderate osteoarthritic changes. The surgeon had estimated that if the progression continued at the current rate, James would be looking at hip replacement surgery within 5 to 8 years. James had spent 40 years in structural engineering. He understood systems. He understood that if a structure failed in two places simultaneously, the cause was likely systemic rather than localized. Both knees had failed. Now his hips were following the same pattern. He wanted to understand why, and he wanted to know whether there was anything that could change the trajectory. When I took a complete nutritional and medication history, the picture that emerged was consistent with what I see regularly in adults with bilateral, progressive joint deterioration. James had been on a proton pump inhibitor for 8 years for chronic acid reflux, which was impairing his mineral absorption. His dietary boron intake, based on a detailed food frequency assessment, was approximately 0.8 milligrams per day. His vitamin D level was 18 nanograms per milliliter, significantly below optimal. His serum magnesium was normal. His RBC magnesium was low. He was boron deficient, vitamin D insufficient, intracellularly magnesium depleted, and his PPI was making all three worse simultaneously. We implemented a comprehensive mineral protocol: boron glycinate at 6 milligrams daily, magnesium glycinate at 400 milligrams before bed, vitamin D3 at 4,000 IU with his largest meal. We worked with his gastroenterologist to reassess the PPI necessity and ultimately reduced his dose significantly. We restructured his diet to include high boron and high magnesium foods daily. At 3 months, James reported that his hip discomfort, which had been a constant low-grade ache on both sides, had reduced significantly. At 6 months, he told me the ache was occasional rather than constant. At 12 months, his orthopedic surgeon, at a routine follow-up imaging appointment, noted that the radiographic progression of his hip joint changes appeared to have slowed compared to the previous year's imaging. His orthopedic surgeon noted it as an interesting observation and did not pursue it further. James pursued it further. He researched the literature himself. He came back to me with 3 published papers on boron and joint health that he had found independently. He was not surprised. He was a structural engineer. He understood that systems do not fail without a cause, and causes have corrections. This was not a miracle. This was the systematic correction of a multi-mineral deficiency that had been depleting his joint tissue for years, and the same systematic approach is available to every adult over 60 watching this video. Number 5. Collagen synthesis, the foundational building block of both cartilage and synovial tissue, requires boron at a specific step in the manufacturing process, and most adults over 60 are producing collagen at a fraction of their biological potential. Collagen is the most abundant protein in the human body. Type 2 collagen specifically is the predominant structural protein in articular cartilage. The synthesis of collagen requires a multi-step enzymatic process involving hydroxylation, cross-linking, and assembly into functional fibers. Several of these steps are directly enzyme dependent. Research published in the journal Seminars in Arthritis and Rheumatism found that morning stiffness duration in adults with osteoarthritis was significantly correlated with serum boron and magnesium levels, with the longest stiffness durations in those with the lowest mineral levels. The action: 2 glasses of room temperature water immediately upon waking before anything else, as I have described in the hydration video, directly addresses synovial fluid rehydration. Boron and magnesium supplementation improves the baseline quality of the fluid being rehydrated. The morning stiffness that most adults have accepted as permanent is in many cases a direct and measurable consequence of mineral and hydration status, and it responds accordingly. Let me stop here at the halfway point. If this video is giving you information about your joint pain that no one has ever given you before, please hit the like button right now. It costs you nothing. It tells this platform that this content is reaching people who genuinely need it. Type the name of your most painful joint in the comments right now. Knee, hip, hand, back, wherever you feel it most. I want to read where the pain is. I want to understand the people watching this video. Type it now. And please think of one person in your life who has mentioned joint pain, who says they just deal with it, who has been told it is arthritis, and that is the end of the conversation. Share this video with that person today, because the end of that conversation is not the end of their options, and this video can reopen the conversation in a way nothing else might. Now let us finish with the 4 most critical items on this list. Number 3. The specific form and dose of boron supplementation that clinical research supports for joint pain in adults over 60. I want to be as precise here as I was about magnesium forms in the leg cramp video, because the form genuinely matters, and the timing genuinely matters, and getting both right is the difference between noticing a change and concluding that boron does not work. The forms of boron available in supplements include sodium borate, the naturally occurring form that Rex Noonan used in his original research, calcium fructoborate, a form found naturally in plants, and the form used in several modern clinical trials, and boron glycinate, where boron is chelated to glycine for enhanced absorption, the same carrier molecule used in magnesium glycinate. Calcium fructoborate has the most clinical trial support specifically for joint pain outcomes. A double-blind randomized controlled trial published in Integrative Medicine, a clinician's journal, found that calcium fructoborate supplementation at 6 mg per day for 30 days produced significant reductions in the inflammatory markers CRP and TNF-alpha and significant improvements in self-reported joint pain scores in adults with osteoarthritis. 6 mg per day of calcium fructoborate, significant improvements in 30 days. The research-supported dosing range for adults over 60 seeking joint health benefits is 3 to 10 milligrams of elemental boron daily. Below 3 milligrams, the evidence for joint benefit is weak. Above 10 milligrams daily is not generally recommended without medical supervision. The sweet spot for most adults, balancing efficacy and safety, is 6 milligrams per day. Boron has an excellent safety profile. The tolerable upper intake level established by the National Academy of Medicine is 20 milligrams per day for adults. The doses used in joint health research, 3 to 10 milligrams, are well within this range. Timing: boron is fat-soluble and is best absorbed when taken with a meal containing dietary fat. Breakfast or lunch is preferable to taking it on an empty stomach. Unlike magnesium glycinate, which is specifically timed before bed, boron can be taken at any meal with fat present, and there is no need to choose between dietary boron and supplemental boron. They are additive. If your diet includes prunes, almonds, avocado, and raisins daily, you may be getting 2 to 3 milligrams from food. A 3 milligram supplement brings you to the lower end of the optimal range. If your dietary boron intake is minimal, a 6 milligram supplement is appropriate. The action: add boron glycinate or calcium fructoborate at 3 to 6 milligrams daily with a meal. Run the protocol consistently for a minimum of 60 days before evaluating outcomes. Joint tissue rebuilds slowly. The inflammation reduction may be noticeable within 2 to 4 weeks. The structural benefits accumulate over months. Number 2. The complete joint health protocol that addresses every mechanism simultaneously. Single interventions produce partial results. The adults I have seen achieve the most meaningful improvement in joint pain are those who address the mineral environment, the inflammation system, the hydration system, and the mechanical loading system together. Here is exactly what that looks like. First, boron glycinate or calcium fructoborate at 6 milligrams daily with a meal containing fat. This is the foundation. This is what addresses the cytokine pathway, the hormonal pathway, the collagen synthesis pathway, and the vitamin D activation pathway simultaneously. Second, magnesium glycinate at 300 to 400 milligrams before bed every night. As I have described previously, magnesium is required for proteoglycan synthesis in cartilage and is chronically deficient in adults over 60. Together with boron, the mineral system governing joint tissue maintenance is substantially restored. Third, vitamin D3 at 2,000 to 4,000 IU daily with the largest meal of the day. The boron supplementation you have begun will improve the conversion of this vitamin D to its active form. Ask your doctor to test your 25-hydroxy vitamin D level after 3 months on this protocol. The result will be more meaningful than any test taken before you corrected the boron. Fourth, 2 glasses of room temperature water immediately upon waking, every morning. Synovial fluid rehydration begins before the day begins. Your joints should start the day with adequate fluid, not catch up after an hour of stiffness. Fifth, dietary boron reinforcement. A daily serving of at least 1 high boron food, a small handful of almonds, a tablespoon of peanut butter, 10 prunes, half an avocado, a small serving of raisins. These are not supplements, they are foods, and they matter. Sixth, omega-3 fatty acids at 2,000 milligrams of EPA plus DHA combined daily. Research from the Annals of the Rheumatic Diseases found that omega-3 supplementation significantly reduced synovial inflammation and joint cartilage degradation markers in adults with rheumatoid arthritis over a 12-week period. For osteoarthritis, a meta-analysis published in Osteoarthritis and Cartilage found meaningful pain and function improvements from omega-3 supplementation. The anti-inflammatory effect of omega-3s operates through a different pathway than boron's cytokine regulation. Together, they address joint inflammation from 2 distinct directions simultaneously. Seventh, collagen supplementation, specifically type 2 collagen or regular bone broth consumption. Research published in the International Journal of Medical Sciences found that type 2 collagen supplementation significantly reduced joint pain, stiffness, and functional limitation in adults with osteoarthritis compared to placebo. The collagen provides the raw material. The boron and vitamin C provide the enzymatic machinery to use it. This is the complete protocol. 7 components. 4 of them are dietary or free. 3 are inexpensive supplements. And together they address joint health at the mineral level, the inflammatory level, the structural level, and the hydration level simultaneously. And number 1, the most important thing you need to understand about joint pain after 60. Joint pain is not a diagnosis. Joint pain is a symptom. And in the majority of adults over 60, that symptom has a measurable, addressable, nutritional, and mineral component that is being entirely ignored by the pain management model of care. Let me be specific about what I mean by that. When you go to your doctor with joint pain, you receive an examination, possibly an X-ray or MRI, and a diagnosis. Osteoarthritis, grade 1, grade 2, grade 3. The diagnosis is structural. The treatment is symptomatic. NSAIDs, physical therapy, and eventually injection or surgery if progression continues. At no point in this standard of care pathway is anyone measuring your boron level, your intracellular magnesium, your vitamin D conversion efficiency, your synovial fluid hyaluronic acid concentration, your collagen synthesis rate. The structural damage on the X-ray is real. I am not dismissing it. But the X-ray is a photograph of history. It shows what has happened. It does not address what caused it. And the causes, measurable and correctable mineral and nutritional deficiencies, continue unaddressed while the symptoms are managed with medications that, as I described at the beginning of this video, accelerate the structural deterioration they are temporarily masking. A comprehensive review published in the journal Nutrients in 2021 analyzed the nutritional drivers of osteoarthritis across 47 separate studies and concluded that suboptimal intake of boron, magnesium, vitamin D, vitamin C, and omega-3 fatty acids were each independently and significantly associated with worse osteoarthritis outcomes in adults over 60, each independently and significantly, not as background noise, as measurable drivers. And the same review concluded that nutritional intervention addressing these deficiencies, while not a cure for advanced structural joint disease, significantly slowed progression and improved pain and function outcomes compared to standard pharmaceutical management alone. Slowed progression, improved pain, improved function from nutrition in addition to whatever standard care you receive. You did not develop joint pain because aging is synonymous with deterioration. You develop joint pain because your joint tissue has been operating in a mineral-depleted environment, in a chronically inflamed biochemical context, with inadequate raw materials for repair and regeneration for years or decades. Some of that history is irreversible. The articular cartilage that has already been lost does not regrow, but the rate of future loss is not fixed. It is modifiable, and the earlier you begin modifying it, the more of your joint function you preserve. This is number one because it changes the frame. Joint pain after 60 is not a sentence. It is a status report on a correctable deficit, and you can begin correcting it today. I want to tell you about Patricia. Patricia was 68 years old, a retired high school chemistry teacher from Seattle, Washington. She came to me with what she described as hands that were no longer her own. Her finger joints had been progressively stiffening and aching for 3 years. She had been diagnosed with early osteoarthritis of the hands. She had been prescribed celecoxib, a QX2 inhibitor, which provided partial pain relief but did not address the stiffness that was limiting her ability to grip, to write, to play the piano, which she had done her entire adult life. Patricia had stopped playing piano 8 months before she came to me, not because the pain was unbearable, because the combination of stiffness and weakness in her fingers had made playing feel effortful and discouraging rather than joyful. She had accepted it as the end of something. When I took her dietary history, Patricia ate a very clean diet by conventional standards, low in processed food, good amount of vegetables, minimal alcohol. But her boron intake was essentially non-existent. She disliked nuts, rarely ate fruit with the skin, and had never eaten prunes or raisins as an adult. Her estimated daily boron intake was under 0.5 milligrams. Her vitamin D level was 22 nanograms per milliliter. Her RBC magnesium was in the lower third of the normal range. She was taking a calcium supplement for bone health, which she had started after a DEXA scan showing early osteopenia, but without adequate boron to regulate calcium metabolism. The calcium supplementation was producing unpredictable results in terms of actual bone density improvement. We implemented the complete protocol. Boron glycinate at 6 milligrams daily with breakfast. Magnesium glycinate 350 milligrams before bed. Vitamin D3 at 3000 IU. We added omega-3 supplementation and introduced a daily handful of almonds as her dietary boron source, which was the one form she found palatable. We added bone broth 3 times weekly for type 2 collagen. At 4 weeks, Patricia reported that the morning stiffness in her fingers had reduced from approximately 45 minutes to approximately 20 minutes. At 8 weeks, she told me the fingers felt more mobile throughout the day. At 12 weeks, she sat down at her piano for the first time in months. She did not recover full function. She acknowledged that honestly. The structural damage in her finger joints was real and not fully reversible. But the stiffness was reduced enough, the pain was reduced enough, and the mobility was improved enough that the piano became accessible again. She sent me a voice message from her piano bench. She did not say anything. She just played for about 30 seconds. I understood. This was not a miracle. This was correcting the nutritional environment that was accelerating damage in tissue that already needed protection. And the same correction is available to every adult over 60 watching this video. And then there was Barbara. Barbara was 76 years old, a retired physical therapist from Nashville, Tennessee. She knew more about joint anatomy, joint mechanics, and conservative joint management than most adults who had never studied it. She had spent 35 years helping other people's joints function better, and she had watched her own knees deteriorate despite knowing everything the physical therapy literature recommended for osteoarthritis management. Barbara was scrupulous about her exercise, her weight management, her physical therapy protocols. She was doing everything right by the conventional model, and her knees kept getting worse. She came to me not in desperation, but in frustration. She wanted to know whether there was something the physical therapy model was missing. She was specifically asking about nutrition. She had been reading on her own and had come across some of the boron literature. She wanted a clinical perspective. When I reviewed her case, what I found was that Barbara had been doing the mechanical work beautifully for years. She had been maintaining muscle strength around the joint, maintaining range of motion, managing her body weight. The mechanical inputs were excellent, but the biochemical inputs had never been addressed. Her boron intake was low. Her vitamin D, despite supplementing with 1,000 IU daily for 3 years, was still only 24 nanograms per milliliter. It had not risen the way it should have with that level of supplementation. This was entirely consistent with boron-impaired vitamin D conversion. She had been taking vitamin D that her body could not fully activate because the boron needed to run the activation enzyme was absent. We added boron glycinate at 6 milligrams daily. We increased her vitamin D3 to 3,500 IU. We added magnesium glycinate before bed. We added omega-3 supplementation. At 3 months, her retested vitamin D level was 41 nanograms per milliliter, from 24 to 41, on only a modest increase in vitamin D dose. The boron had unlocked the conversion that years of supplementation alone had not achieved, and her knees. At 6 months, Barbara described a subjective reduction in daily knee pain that she estimated at 40 to 50% compared to where she had been a year earlier. Not eliminated, meaningfully reduced. The physical therapy she had been doing faithfully for years began producing better functional results because the joint tissue it was working with had improved biochemically. Barbara told me that in 35 years of physical therapy practice, no one had taught her about boron. She said she intended to add it to her practice's patient education materials. This was not a miracle. This was the biochemical foundation that made the excellent mechanical work she had been doing all along finally produce the outcomes it should have been producing for years. And the same foundation is available to you. Here is your complete action plan for joint health. Specific, evidence-based. Starting today. Step 1. Begin boron glycinate or calcium fructoborate at 6 milligrams daily, taken with a meal containing fat. This is the foundation. Take it every day. It is not optional on days you feel better. Consistency over 60 days minimum is required for the full benefit to manifest. Step 2. Add 1 high boron food to your daily routine this week. 10 prunes, a small handful of almonds, half an avocado, a tablespoon of peanut butter. 1 high boron food every single day. These are dietary reinforcements of the supplementation, not substitutes for it. Step 3. Add magnesium glycinate at 300 to 400 milligrams before bed if you are not already taking it. As I described in the leg cramps video, the form matters entirely. Magnesium glycinate only, not oxide, and before bed for overnight joint tissue support. Step 4. Ask your doctor at your next appointment to test your 25-hydroxy vitamin D level if you have not had it done recently. If it is below 40 nanograms per milliliter, discuss supplementation at 2,000 to 4,000 IU of D3 daily. If you have been supplementing D3 for years without achieving optimal levels, tell your doctor you are adding boron and ask them to retest in 3 months. The level should move. Step 5. Drink 2 glasses of room temperature water immediately upon waking before anything else every single morning. Synovial fluid rehydration is a daily process. Every morning you skip it is a morning your joints begin the day depleted. Step 6. Add omega-3 fatty acids at 2,000 milligrams EPA plus DHA combined daily. Sardines 3 times a week provide this from food. A high-quality fish oil supplement providing these numbers specifically is the supplemental alternative. Read the label for EPA and DHA milligrams, not total fish oil milligrams. Step 7. Consider adding type 2 collagen supplementation or 2 to 3 cups of bone broth weekly. This gives the joint the building material it needs to use the enzymatic machinery that boron and vitamin C are restoring. Timeline of what to expect. Within 2 to 4 weeks of beginning the boron protocol, reduction in morning joint stiffness duration is typically the first improvement noticed. Within 4 to 6 weeks, reduction in baseline joint pain levels during normal daily activity. Within 8 to 12 weeks, more significant improvements in joint mobility and reduced pain with moderate activity. Within 3 to 6 months, the full cumulative benefit of restored mineral environment, reduced inflammatory burden, and improved collagen synthesis is measurable. These are timelines from clinical research, not promises. Individual responses vary, but they are consistent enough across the evidence base to serve as a meaningful guide. Let me cover the 5 mistakes that will undermine this protocol if you make them. Mistake 1. Expecting boron to act like an NSAID. It does not. NSAIDs produce pain reduction within 30 to 60 minutes by chemically suppressing inflammation. Boron corrects the underlying mineral environment that produces chronic inflammation. The timeline is different, the mechanism is different, the outcomes are different. If you take boron for 2 days, feel no immediate change, and conclude it does not work, you have made the error of evaluating a nutritional rebuilding process on a pharmaceutical timescale. Give it 60 days, consistently, daily. Mistake 2. Taking a low-quality supplement with inadequate elemental boron content. Some boron supplements list total milligrams per capsule as the weight of the boron compound, not the elemental boron content. A 100 milligram capsule of a boron compound may contain only 2 to 3 milligrams of actual elemental boron. Read the label. The label should specify elemental boron content. The target is 3 to 6 milligrams of elemental boron per day. Mistake 3. Correcting boron alone without addressing the connected deficiencies. Boron without adequate magnesium produces partial results because magnesium is required for the proteoglycan synthesis that boron's reduced MMP activity is trying to protect. Boron without adequate vitamin D produces partial results because the hormonal benefits of boron steroid hormone support are blunted in a vitamin D insufficient environment. Address the system. Mistake 4. Stopping the protocol at 30 days because the improvement seems modest and concluding that the direction is wrong. Joint tissue is among the slowest rebuilding tissue in the body. Cartilage turnover is measured in years, not weeks. The 30-day mark is typically where the inflammatory markers are shifting and the stiffness is beginning to improve. The structural benefits continue accumulating for months. Partial improvement at 30 days is evidence that the protocol is working. It is not evidence that it has worked as much as it will work. Mistake 5. Feeling that pursuing nutritional joint health is a lesser or less legitimate approach than pharmaceutical management. I want to address this directly. The peer-reviewed literature supporting boron, magnesium, vitamin D, omega-3s, and collagen for joint health is substantial, published in respected journals, and conducted through rigorous trial methodology. These are not folk remedies or marketing claims. They are the same level of evidence that informs pharmaceutical treatment guidelines. The reason they are not in those guidelines is not insufficient evidence. It is the structural incentives of a medical system where non-patentable, inexpensive minerals do not generate the research funding that pharmaceutical products do. You are not opting out of evidence-based medicine by addressing mineral deficiencies. You are practicing it. You are not broken. Your joints are not simply aging. The nutritional environment your joints have been operating in was broken, and now you have the information to begin repairing it. Let me recap all 10 points one final time. Number 10. Long-term NSAID use accelerates cartilage loss while reducing pain. It is a trade-off documented in peer-reviewed literature that is rarely explained to patients. Number 9. Geographic boron data shows arthritis prevalence correlates directly with soil boron levels, 10% where boron is high versus 70% where it is low, a finding supported by 40 years of research. Number 8. The average adult over 65 in the United States consumes 1.1 milligrams of boron daily, against a research-supported optimal of 3 to 10 milligrams, a deficit that is silently driving joint deterioration. Number 7. Boron and magnesium deficiencies compound each other in the joint environment. Boron deficiency impairs magnesium retention even when magnesium intake is adequate. Number 6. Boron activates the enzyme that converts vitamin D to its active form. Adults who have been supplementing vitamin D without seeing expected improvements may have boron deficiency as the missing piece. Number 5. Boron is required for the collagen hydroxylation step that determines cartilage structural strength, and for hyaluronic acid synthesis that determines synovial fluid lubricating quality. Number 4. Morning stiffness duration is a direct measure of synovial fluid quality and mineral status, not an inevitable consequence of aging, and it responds to mineral and hydration correction. Number 3. Calcium fructoborate or boron glycinate at 6 milligrams daily with a fatty meal, taken for a minimum of 60 days, is the research-supported protocol for joint pain in adults over 60. Number 2. The complete protocol. Boron, magnesium glycinate, vitamin D3, morning water, daily high boron food, omega-3s, and type 2 collagen addresses joint health at 7 simultaneous levels. And number 1, joint pain is not a diagnosis. It is a symptom of a correctable mineral deficiency operating in a system the standard care model was never designed to address nutritionally. The X-ray shows history. The mineral protocol changes the future. Here is my challenge to you. Commit to just 3 things, not all 7 steps. 3. Starting today. Order boron glycinate this week and begin 6 milligrams daily with breakfast. Add 1 high boron food to today's meals, a handful of almonds, 10 prunes, half an avocado, and drink 2 glasses of water before anything else tomorrow morning. Just those 3, starting today. Your joints have been working for every step you have taken, every staircase you have climbed, every morning you have gotten out of bed for over 60 years. They have done this without complaint, without asking for anything, absorbing the mechanical forces of a full human life, and they have been running without the mineral they specifically need to maintain the tissue that makes all of that movement possible. The pain you feel is not your joints giving up. It is your joints telling you what they have been missing, and what they have been missing is inexpensive, available at any grocery store and health food shop, and has 40 years of research saying it matters. You are not broken. Your joints are not simply old. The mineral environment your joints have been living in was broken, and today you can begin building it back. Please subscribe to this channel. I release new information like this every single week for adults over 60, information designed to give you the specific answers that a 15-minute doctor's appointment was never able to provide. Ring the notification bell. Type in the comments which joint you are most committed to protecting. The comment makes it real. Share this video with one person whose joint pain you know about. One person, that is all. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.